Well, good evening all. It is just past 6 o'clock and I'm delighted to welcome you to this webinar, which is part of our bi-weekly series. And it covers a very important topic of which there are recent advances and recent updates that I think every one of us needs to be familiar with. Certainly, one of the most challenging things we come across as surgeons is sepsis, and recognizing it at a time when intervention can make the difference between survival and either gross morbidity and weeks in the intensive care unit, or regrettably somebody not surviving the episode, is essential. So awareness of sepsis and the early warning scores and what to do about it is absolutely vital to practice at all levels. So I think it's a really important topic, and there are recent advances in understanding and managing sepsis. And I'm very grateful to our faculty this evening. Gerard McCarthy, who's the National Clinical Lead in Emergency Medicine, will give the introduction and act as session chair. Then Martina Healy, who is the National Clinical Lead for Sepsis. I just see Martina has joined us. Hello, Martina. We'll talk about sepsis surgery and the new clinical guidelines. And this, again, as I say, is exceptionally important. And then Simon Walsh, who's a consultant in emergency medicine in Cork University Hospital, is going to talk about recent advances in the management of sepsis in the ED. And again, this is where it has to be picked up, triaged appropriately and managed, because too often there are delays while and antibiotics and the sepsis 6 have not been administered in that critical first hour. So these are things that I hope you'll take away from this. I'm really buoyed up to know that we've got over 400 people registered for this webinar. I'm not sure how many. It's close to 100, I think, now online. And I'm sure there will be others joining us. It will be recorded and available to revise if you wish to revise or to look back on things, or for your colleagues who've missed it, please do tell them to have a look at it, because I really do think this is such an important topic. And I look forward to hearing from our colleagues. So I'm going to hand over to Gerard McCarthy and ask Gerry, would you be kind enough to take the webinar on from here? Thanks, Gerry.
Certainly. Thank you, President. I think you've certainly set the context and importance of this session this evening. And whilst advances in understanding and treatment of infectious disease itself over the last couple of centuries has moved it way down the common list of causes of morbidity and mortality, we've been continuously reminded of the importance of societal behaviour as much as medical treatments in the control of infectious diseases during the last 18 months of the pandemic. And here we are on the webinar tonight as a result of that. However, moving on to a much more important specific aspect, over the last couple of decades, we've advanced our awareness and understanding of the particular issue of sepsis rather than just infectious disease as a wider entity. To what extent we've improved the identification and treatment of it is the subject of this evening's webinar. So just before I introduce our first speaker, I'd like to emphasize that we do recommend that people turn off their video and their microphone during the sessions, as it improves the reliability of technology and is less of a distraction for the speakers. So I'm delighted to introduce and welcome our first speaker, Dr. Martina Healy, consultant in Paediatric Intensive Care at CHI Crumlin and lead of the National Sepsis Programme. Thanks, Martina.
Thank you very much. So first of all, I would like to thank the RCSI for inviting me to give the lecture. And secondly, I think what Ronan O'Connell has said as first part really summarises what the lecture is all about. I'm going to provide some figures from the national picture the audit group have been doing for the last 5 or 6 years. And then I'm going to present some of the new guidelines and the slightly small changes that have been made in the definition of sepsis. I'm very happy to take questions after. And closest to my heart, I'm actually going to do a little bit on paediatric sepsis, because particularly for the ED group, these children can turn up anywhere at any time in any ED around the country. And I think they're particularly difficult sometimes to interpret from a sepsis perspective. Next slide, please. I don't have control of my slides here, so I'm just going to ask for the next slide, please. So I think the context of the National Clinical Programme for Sepsis was originally started in 2013 when a national steering committee was established and a clinical lead appointed. The first clinical lead then established the National Clinical Guidelines for Management of Sepsis, and these were originally called the Sepsis Number 6. And they were published and endorsed by the Minister for Health. And I think a lot of you will remember a patient from the West who died of sepsis really initiated this, but it was needed and a very timely time to start. As a result of the intervention by the HSE Department of Health and the Minister for Health at the time, a programme manager and 6 sepsis aid-on directors or assistant directors of nursing were appointed to cover the 6 hospital groups and maternity. And again here, unfortunately, paediatrics was omitted. I'm going to have a bit of a moan during this lecture while I can about peds. And that subsequently led to the publication of the adoption of the international guidelines and being accepted by the National Committee of Clinical Guidelines as the Irish guidelines. So next slide, please. So I'd like to talk about the National Sepsis Report 2019 and give you some context into the numbers that the surgical sepsis group in particular represent, and then a little update on the National Clinical Guideline update. And I'd like to show you the HSELand e-learning update, and which is available online for everybody, and talk about the launch of the Paediatric Sepsis Management Guidelines. Next slide, please. So the epidemiology of sepsis in Ireland. So we can see, just to have a pointer there, in 2011, before the national guidelines and before the public awareness campaign really came into effect, there were actually what looked like a small number of patients being represented on the epidemiology of sepsis in adult hospital groups. And we can see that it varied from 6,000 to 7,000 to 8,000. The intervention of the national guidelines and public awareness thing made it go from 8,000 to up to 16,000, 17,000. And it isn't that the incidence of sepsis actually increased. It's more that the awareness and the reporting of sepsis suddenly became an issue, and that people were actually willing to record it, and it was coming up on our audit data as actually being recorded as sepsis. And we can see there's a little star here between 2017 and 2018. The definition of adult sepsis changed slightly, and this changed the numbers that were actually being identified, and to some extent the mortality, and we'll explain why in a little while. Next slide, please. So what is surgical sepsis in particular? The audit specifically refers to inpatients with a surgical diagnosis related group, which is assigned if there's one significant surgical procedure carried out in the operating room during the episode of care. So because this has showed up in the audit group of being of such significance in mortality and morbidity, this is now red flagged as an actual increased risk. Next slide, please. So the total number of patients in adult patients in hospital with sepsis, this looks at both surgical and medical. And as we can see, the majority of patients are actually in the medical subgroup. And this isn't surprising. The majority of patients in hospital are actually in the medical subgroup. And the surgical subgroup of inpatients with sepsis represent a high number of inpatient actual lengths of stay. Next slide, please. So, and crude mortality, and we can see that the crude mortality for surgical sepsis in the adult group has remained at above 25% constantly, despite the implementation of the adult guidelines and quite a comprehensive in-hospital sepsis committees and flagging of sepsis as an entity. So the medical sepsis rate mortality has actually reduced from 2015 to 2019, and to such an extent that it's now recognised that the effect of surgery on morbidity and mortality is of such that it gets a actual it's actually red starred as a high risk group in itself. And this is represented in other states worldwide because it's important to actually benchmark our results with international figures and see where Ireland stands in both morbidity and mortality. Next slide, please. So I suppose the first question is the introduction of the guideline in 2014. Did it have an impact? And if it did, in what patient groups? Next slide, please. So these slides represent crude hospital mortality, taking from HYPE data from 2011 to 2019. As we can see, pre the introduction of the National Clinical Guidelines, there was a crude mortality rate, and it is crude mortality, of up to between 27 and 29% mortality in all patient hospital groups within this time. Then rollout of the first guideline between 2014 and 2015, the mean hospital mortality reduced to 23% pretty rapidly with the introduction of the first set of guidelines. And then with the introduction of the second set of guidelines, the mean rate on our last annual report had reduced to less than 20% or 19.7. Now, obviously, these are fairly quick groups, but it is obvious that these guidelines and teaching, education and recognition are having an effect, and they do work. Next slide, please. I think what's really interesting when you break down the length of stay for sepsis patients, surgical versus medical, we can see that the surgical patient represents 2.5 times the stay of a medical patient if they have sepsis within an in-hospital stay. Next slide, please. And it isn't just its effect on morbidity and mortality. For those, and all of us are interested in cost and cost per stay and cost per day, this represents double the amount, at least, of the in-hospital stay for these patients. So this is probably an underrepresentation of the actual cost, because the cost per day for a patient with sepsis is actually going to be a lot more for a patient without infection. These costs per day are actually based on patients in hospital stay without the added cost of extra antibiotics and nursing and medical care for the sepsis and septic shock group. Next slide, please. So before we go on to the guidelines, the effect of, so you can ask the question, why does surgery and why do surgical patients have such a high both morbidity, mortality and length of stay? And I think it's probably recognised now that the immunosuppressive effect of surgery is probably something we need to look at more closely, and that these patients, even though they get the same treatment and early recognition and management with antibiotics, they're actually at increased risk because in itself they've actually had surgery. And I think we need to be looking very carefully at local sites, at different microorganisms and sites of infection. And each patient group, particularly in surgery, should be looking at surgical site infections with respect to the site of surgery, and is there a particular group of patient getting a particular organism post-operatively. I think a lot more work has to be done at local level to try and identify these high-risk patients and reduce both the morbidity and the mortality. So next slide, please. Like we said, the Sepsis Management National Clinical Guideline was initially called number 6, published in 2014. It included a section on mainly adult sepsis, the management of maternity and auditing of maternity sepsis, and a small section on paediatrics. Next slide, please. Where we are now, so currently we're on number 26. It isn't that we've actually produced 25 or whatever it is, 20 of them in the meantime. This is the way the system works. The last guideline is called number 26. It does include maternity, and the first guideline for paediatric sepsis was published in September 2021. Next slide, please. So where are we now? So adults, including maternity. The updated National Clinical Guideline for Sepsis is an adaptation of the Surviving Sepsis campaign, updated in 2018. It is available on the Department of Health website. Next slide, please. So 93 recommendations were made in the new number 26 or old number 6 guideline. But the main recommendations really are initial recognition and awareness, screening for sepsis, the resuscitation and the antimicrobial therapy varies within local sites, but pretty much hasn't changed. But I think setting goals of care is one at the very end there, that I think that locally people can make a difference in morbidity and mortality. Next slide, please. Clinical judgment. So when you give people forms to fill in and guidelines to follow, often common sense goes out the window. And I think we're very aware that these guidelines and these forms should never replace clinical judgment. And if your feeling is your patient isn't doing well, and that things aren't going as planned, and the patient isn't at the place where they should be within their hospital stay, you should consider sepsis. And a lot of the time, the forms that I'm going to show you now are actually about asking the question, could this be sepsis, at a very early stage in the patient's stay. Next slide, please. So, very quick definition. It is a life-threatening organ dysfunction caused by a dysregulated host response, and you must initially have an infection. And the same for the maternity septic group, and it results from infection during pregnancy, childbirth, post-abortion or postpartum period in the first 39 days post-delivery. Next slide, please. So the change in definition that came about in 2016-2017 was really the initial definition of sepsis came from a systemic inflammatory response definition of sepsis. And the overall sensitivity of this group, and it was felt that there were a cohort of patients who didn't have a life-threatening sepsis, and his clinical course was they were being flagged and wouldn't be impacted, but there was a failure to recognise another group who did have life-threatening organ dysfunction and that would benefit from escalated care, and there was a lack of specificity to the SIRS group that can be triggered by many non-infective insults. So the definition was changed to include a high-risk group. Next slide, please. And really, these are the group that are of the most, this is the group we're trying to avoid. So septic shock is a subset of sepsis, and any septic patient has the potential to go into septic shock. And this is defined as sepsis with circulatory and or cellular metabolic dysfunction, which is associated with a very high risk of mortality. And the definition has defined this as the requirement for vasopressors or inotropes. And I know our next speaker is going to speak about that and intervention early in ED, with the option or with the goal of trying to achieve a mean arterial pressure of greater than 65 or a lactate less than 2 despite adequate fluid resuscitation. So the definition is to identify a cohort of patients with a mortality risk of greater than 40%. So the septic shock group are the group we want to prevent from going into the mortality group if at all possible. Next slide, please. So Sepsis 6 is actually the name given to the bundle of actual therapies designed to reduce mortality. A quick way, take 3 and give 3. Next slide, please. Plus 1 refers to the fetal child. The 3 and 6 hour bundles, which were initially presented in the first set of guidelines, have been actually combined into a single 1 hour bundle. And the intention really is to begin resuscitation and management immediately when you think the patient may have septic shock. So for patients who present with clinically apparent sepsis or septic shock, it's recommended that sepsis bundle be administered, start the clock immediately and give everything within 1 hour. But if it's an infection included in the differential diagnosis and it's in one of these at-risk groups, the 1 hour is an hour pre the 1 hour stop clock is allowed for screening and medical review. And once completed, if you're falling into the group of septic shock, this is considered time 0. All elements of the sepsis 6 bundle are then to be initiated within 1 hour of time 0. Next slide, please. So these forms really are designed to be a clinical decision as support tool. So they're there for two reasons. They're there to enable clinicians, including nursing staff and allied medical staff, to reduce unnecessary variation in practice in the local treatment of sepsis, and also to think of sepsis and often to a rule sepsis if it's used as a guide or an aid. There is an adult sepsis form, a sepsis predisposition and recognition form for the maternity group, and at the back there is a fluid resuscitation algorithm for adults with sepsis. So there are two sides to the form. Only one side has to be filled in, and the back of the form is meant to be an aid memoir or a help and advice for the treatment of sepsis. So the important thing is to have it in your head and consider the form. Next slide, please. And the same for the maternity and fluid resuscitation forms. They are an aid memoir or a reminder maybe to consider sepsis in a patient that you're just not happy their treatment is reaching its goal. Next slide, please. So we have spent a lot of time upgrading the e-learning module on adult sepsis, which includes the maternity on HSELand. And we'd like all staff involved in the recognition and management and escalation of treatment for sepsis to actually read and get involved in this e-learning module. And it's to help the user to recognise and manage sepsis in the adult population. We're currently putting together an e-learning module for paediatrics, and it does include the maternity patient group as well. It takes approximately 1 hour to complete, and it has 2 CPD points for awarded to the people who take part in it, and it's valid for 3 years. Next slide, please. So we had and did introduce paediatrics or adult sepsis guidelines, and there was always a big gap. One of the most difficult, I think, patients in the ED, particularly in the non-paediatric ED, is the child who comes in who has the potential to develop sepsis, or it may be difficult to differentiate between sepsis and infection and where you start treatment or where you should initiate treatment or call for help. And these are new national guidelines with a local implementation plan included in the guideline. Next slide, please. So in February, it took a long time for the international group to agree a definition of paediatric sepsis and to agree surviving sepsis guidelines for the management of organ dysfunction in children. And it had to cover a wide range of countries, obviously, and treatments. And they did so very nicely, published in Intensive Care Medicine in February 2020. Next slide, please. And these guidelines then triggered us as the National Clinical Group for Sepsis to actually put together a multidisciplinary PED sepsis working group. And after numerous meetings, we recommended the adaptation with some local changes of the international guidelines to become the national guidelines for sepsis for children. Next slide, please. So it contains 77 statements on the early management and resuscitation on children with septic shock and sepsis-associated organ dysfunction, with some points to assist clinicians in the management of PED sepsis in the Irish healthcare setting. Next slide, please. So the big ticket items in the PED sepsis were the definition of septic shock, what fluids to use, and recommendations in PED sepsis. A specific 1 hour time to treatment from those in shock, but it actually allowed up to 3 hours, and there is a reason for this, in that triggered early and too early was causing problems internationally, particularly in the States. So they allowed for up to 3 hours in those patients without septic shock. A nice definition of hypotension, and then some suggestions on broad spectrum antibiotics, but obviously local guidelines are more useful when they're available in your own institutions. Next slide, please. So 2 big questions really repeat sepsis. How do we identify these children who will gain most from early intervention, and what should these interventions be? And I'm just going to spend 2 or 3 slides on this, and then I'm going to stop and see anybody have any questions. Next slide, please. So we spent a long time designing a paediatric sepsis form that would represent a broad spectrum of children presenting with infection with the potential to actually become septic shock. And this is now and will be available on the website and with the guidelines. The back page is a treatment, reassessment and referral form, and the only part that has to be filled in is the first form. And just on some, we've done some, we've sent it out to some of the regional EDs and regional paediatric centres, and what we got back was a reassurance that they felt the form was useful, particularly where you have a patient where you're not sure whether this could be sepsis and if you should be referring on, or where you felt, yeah, this is a definitive intervention and this child potentially could be going towards septic shock. Next slide, please. Most at risk in peds, less than 1 year of age, low birth weight, prematurity, serious injury, any host immunosuppression, malignancy, virus, severe malnutrition, all of those things, and large surgical incisions is in there. Within our local practice here in Crumlin, we would have a number of patients with surgical site incisions, particularly in the cardiac surgical group, that we've worked very hard on to try and reduce the incidence of. And obviously any child with indwelling vascular devices such as Broviex, CVCs and other Foley catheters and chest tubes. Next slide, please. So the difference between adult and paediatric sepsis, and this is the one that probably causes the most confusion. So in adults, normally an adult with sepsis will have a low blood pressure. Children are different. Only about 15 to 20% of children will present with hypotension. Children typically present with a high systemic vascular resistance, and so the blood pressure when it's measured in the ED or on the ward is often high. A real key to ped sepsis is the recognition of an unexplained tachycardia with a high or very high blood pressure. And often this high blood pressure in children actually reduces their cardiac output, and it's difficult to pick up unless you're actually echoing these children. So with an increased systemic vascular resistance, their cardiac output is reduced. But things like cap refill time and urine output are really useful. Next slide, please. So I think one of the big international campaigns for sepsis was a child who presented to a New York ED with a low white cell count and really very little or no other signs or symptoms. Low white cell counts in children are common, and it's often with a neutropenia, and it can be difficult to spot it on a white cell count where everything else is normal. In the setting of an ill child, though, with or without a normal, an altered GCS, I think it's important to maybe follow on with a blood culture or a urine check and so on. Next slide, please. So I think the red flags in peds are if our experienced peds group or ED group are having problems inserting IVs or unable to get an IV cannula, I think that's a red flag. Unable to take blood for a period of time, parents mentioning cold feet, legs, or just parental concern in itself is often a red flag. Cool peripherals with large core peripheral temperature differences in children, another red flag. Next slide, please. So these are our aims in children: cap refill time less than 2 seconds, normal pulse, and unexplained tachycardia should always be up there. Probably a mean arterial pressure of greater than 45 for any weight of child, and a urine output of greater than 0.5 mils per kilo per hour, and a lactate of less than 2 or falling. Next slide, please. So a take-home message for, and I'll just point you out the paramedic unit there with the sepsis on the guidelines. So together with our program manager, Kira Hughes, we spent a lot of time and effort on a public awareness campaign and getting the paramedic units and the ambulance units to have a sepsis flag on the side of the ambulance has taken a lot of effort and time. And these have now appeared on nearly every ambulance, and I'm really pleased to see it. We feel that education, awareness, early recognition, targeted treatment saves lives, and it applies equally not just to us as clinicians, but to the public and the carers in particular, whether they're parents or whether they're older carers, as well as clinical staff. And we feel that public awareness on sepsis saves lives, and that includes all of us. So I think that's the next slide is just what's available online for further teaching on this. I hope I haven't run over time. Thank you very much. And anybody want to ask any questions?
Martina, I must congratulate you on having us exactly halfway through the seminar now. Thanks for the webinar. So thanks very much for a very informative and thought-provoking talk. President, I think you have your hand up.
Thank you, Martina. Wonderful talk, and very important that you highlight the difference between adult and childhood sepsis, because certainly many of us, including myself, were not aware of the subtle differences. I just wanted to pick up in adult practice, we would have felt a rising lactate, and a lactate greater than 2 was the issue, whereas you've identified it as less than 2 and falling.
I think that's actually a mistake, Ronan. I just seen that on there. Not less than 2. No, a rising lactate in adults is always significant. I think well said.
And in children?
In children, lactate is probably more difficult to define. Often getting blood from children with sepsis is quite difficult. And I think that by the time you get to the rising lactate in children, it's actually quite late on. And that is one of the real difficulties in managing sepsis in children. And maybe your next speaker, Simon, I don't know if you have something to say on this, but relying on, I think, blood gases and so on to see changes on may be a bit late. I think in children, unexplained tachycardia is the one thing when you go back over POCUS charts that is often there for a period of time. With hypertension in particular and a temperature are probably the real key physiological changes in children. And I think parents concerned that their children are not getting better from an infection is a really important one. I would say in adults and children, the feeling that I'm not where I should be, I've had a bad cold, I've had an operation, they're not recovering as they should, is a real red flag.
Well, indeed, in my own practice as a colorectal surgeon, if on day 3 after an anastomosis, somebody is not on the trajectory, there's a leak until proven otherwise.
Absolutely, absolutely, and I don't think it's any different in the child who has a central line in that you're thinking they just don't look as well as they did yesterday, or even the non-ICU patients, the unexplained tachy with the intermittent temperature. You've got to be getting in there early, and it's the only way.
Thanks. I don't want to hog things. Thanks very much, Martina and Jerry.
Thanks very much indeed. I think we might hold other questions. I have some already until after Simon's talk. Can I remind people of the chat function? If they want to ask questions, we have some already. Can I also repeat that we would prefer if people turn off their videos and microphones during the talks. And it's now my pleasure to introduce my colleague from Cork University Hospital, a consultant in emergency and retrieval medicine, Dr. Simon Walsh, who has a particular interest in this area of sepsis. And over to you, Simon. Thank you.
Good evening, everybody. So thank you for the invitation to speak tonight, and thanks for Dr. Healy's talk. It was excellent. So I'm going to talk about emergency sepsis in the emergency department and how we manage that. Next slide. So, as Dr. Healy mentioned, sepsis is the syndrome of life-threatening organ dysfunction resulting from dysregulated host response to infection. And the conservative estimate is that it's about 6 million deaths per year. Early appropriate antibiotics is the treatment and source control when indicated. And if you don't give antibiotics in septic shock, the mortality increase per hour is 7.6%. So, as we've mentioned earlier on, so the Many Rivers trials from 2001 showed that mortality rates in sepsis was about 40%. Next slide. But that has improved over the last 20 years. So obviously we're going to talk about resuscitation today in the emergency department. Next slide. But it's not just about resuscitation. Sepsis identification in the emergency department is the other aspect. So you need to be able to recognize the patients that are coming in and who's sick. So if you're getting 150 to 280 patients coming through the door of your emergency department, how are you going to filter out the ones that are sicker? So we use triage. So the Manchester triage score is based on physiological parameters. Next slide. So that looks at heart rate, blood pressure, temperature, SATs, resp rate, and GCS. And these are all physiological parameters that are on the SIRS criteria. So you're looking at the same kind of information. And there's early warning scores that are used as well to try and identify patients who are going to get sick. So normally these are used on the ward, so EMEWS, POCUS, NEWS. But recently we're trying to implement this in the emergency department as well due to kind of long waiting times. Next slide. Next slide, please. And these EMEWS scores have been shown to reduce mortality. So that if you're on the ward and you've got a high EMEWS score, it gives the nurses an ability to call a medical team or to call an ICU team to come and help and look at that patient to see if they've got anything that needs, they might need to go into intensive care or they might need resuscitation. So this form here is just a sample one, so of a triage score. So you can see that the patients on the left, the red ones, have kind of worse physiological signs, and that extends over to the green ones. And up the top, you can see some triaged, some times to review. So next slide. So the Manchester triage scale, so you can look at this. So the immediate one, so if you're a triage score of 1, you need to be seen immediately. So that's your unconscious patient coming in, or a GCS of 5. They need to be seen straight away. There's no waiting for those patients. And your triage 2 is the patient with chest pain. And ideally, we want to see those patients or have an ECG done within 10 minutes. Next slide. But as I mentioned, sometimes patients are having to wait longer than those times. So the EMEWS, so the Emergency Medicine Early Warning Score, is being rolled out around the country now to try and get the nursing staff to review those patients who come in who are Cat 2, 3, or 4, so that they can not get missed or not missing sepsis or early signs. Next slide. Next slide, please. So the key points of my talk. So you got to recognize sepsis early, all right? Early appropriate broad spectrum antibiotics, do blood cultures, source control where indicated, fluid resuscitation, choosing the right fluids, involving critical care early, and don't delay with vasopressors after you've adequately fluid resuscitated the patient. Next slide. So Dr. Healy already alluded to this document. So this is the sepsis form that we use in the emergency department. And there's some really good points on this. Next slide. So the Sepsis 6 treatment bundle that Professor O'Connell was talking about. So really good information. So take your blood cultures, take your blood tests and your lactate, measure urine output, give your antibiotics, give your IV fluids and oxygen when needed. Next slide. And it also mentions the SIRS response. And I know Dr. Healy had spoken about this, but I suppose they tried to bring in the Q-SOFA score in with one of the sepsis guidelines, and it probably wasn't sensitive enough. So I feel that in the emergency department, where we're getting those undifferentiated patients coming in, 200 patients a day or 250 patients, and one of the key things for us is to not miss anything. So I think that having a high sensitivity, even if the specificity is low, it'll raise our awareness for the ones that are ticking the box that might need us to consider sepsis. Next slide. So now I'm going to talk about resuscitation. Next slide. Next slide, please. So the key points from the Surviving Sepsis Task Force this year, so from April of this year, they had 3 questions. So what are the ideal endpoints for volume resuscitation, and how should volume resuscitation be titrated? What's the optimal fluid for sepsis resuscitation? And what is the optimal approach to selection, dose titration, and escalation of vasopressor therapy? Next slide. So we're going to go through each of these questions, and it'll be interesting to get feedback from the intensive care guys at the end. So what are the ideal endpoints of volume resuscitation? and how should volume resus be titrated. So don't go straight to vasopressors, okay? So you need to assess fluid responsiveness first. So there is evidence out there that if you go in too soon with vasopressors and you don't fluid resuscitate the patient, you're going to increase mortality, all right? The optimal amount for individuals varies. So when I started doing emergency medicine, everybody got 2 liters of fluids. That's how you treated sepsis. But the studies have got a wide range. So 15 to 45 mils per kilo is optimal, is what they say, but that's far too broad for clinical practice. So we picked 30 mils per kilo, which is in the middle, and that will give the average 70 kilogram man about 2 liters, okay? But it'll stop the 40 kilogram little old lady getting 2 liters as well. But we also know that excessive fluid increases mortality. So somebody who is 70 kilos might only need 1 liter of fluid, and then they need vasopressors, whereas somebody else might need 3 liters of fluid. In the intensive care, they've got the ability to do pulmonary artery occlusion pressures, measure CVP, transpulmonary thermodilution, but none of this is applicable to the emergency department. But what we do have is point of care ultrasound. Next slide. Next slide, please. So this is just an image of a lung. So this is looking at B lines in the lung. So looking at the white line at the top is your pleura, and this is looking down through your lung window and seeing these multiple kind of white lines that are extending down vertically to the bottom of the image. Okay, so these are B lines. So these signify, if you've got, you need to have these in 2 different locations in the chest. Okay, and if you've got more than 3 of these B lines, that signifies that the person has interstitial syndrome. So they're either going to have fluid in their chest, they're going to have cardiogenic shock, or acute pulmonary edema. If they've only got it in one location, that might mean that they just have pneumonia or a local or focal pneumonitis. Next slide. This is a video. It might work. So this is what it looks like. Just a short YouTube clip looking at interstitial syndrome. So you can see those as you're scanning the person's chest. You can see those white lines moving across. You need to have more than 3, and that signifies that the person's got interstitial syndrome. So that's a guide that the person is fluid. Next slide. So that's a guide that the person has got fluid in their chest, and they probably don't need any more fluid. Next slide. Coming up now. So the next one is looking at the IVC. So this is hotly debated. So, but I use it in my practice. So looking at this slide here, you can see that the IVC is not collapsing with respiration. So it's only a still image, but if you're looking in real time, you'll see that the IVC should collapse with respiration. And if the IVC is not collapsing at all and it's full, that means that the person is fluid replete. So I would not want to give this person any more fluid. Next slide. Whereas if the IVC is collapsing with respiration, next slide, thanks. If the IVC is collapsing with respiration, then you know that the person will probably tolerate some more fluid. This is debated, and some people think that IVC doesn't work, but I think it's a guide, and if you use it with your ultrasound of your lung and with your clinical acumen, it will guide practice. So this was a study from Australasia, so the ARISE fluids trial, so from 2020, and they found that there was too much heterogeneity in the fluids used in sepsis resuscitation, and that if you had given more fluid within the 6 to 24 hours, there was an increase in organ dysfunction. Next slide. And this was another interesting study from a few years ago called the ANDROMEDA shock trial, and they compared your cap refill time to lactate. So they had they calculated their sample size at 440 to show a mortality reduction from 45 to 30% if they used a lactate of less than 3 to give more fluids, and if your cap refill time of less than 3 to give more fluids. But if your cap refill time was more than 3, you would give fluids, and if a lactate was more than 2, you would give more fluids. So what they found was there was a trend towards increased mortality with more fluids, so 43.4% versus 34.9%. It wasn't statistically significant, but they probably just needed more numbers. And I think that their target of 45 to 30% was quite large. Lactate does take a while to respond to rehydration. So if you've given somebody adequate fluids, your lactate will probably not come down for quite a while. So if you're still giving them more fluid for the lactate, you're probably going to be giving them more fluids. And as we said before, that will increase mortality. So next slide. So please don't chase the lactate. Next slide, please. So I think the lactate is important. It's really important that it will guide your resuscitation. So giving somebody, checking a lactate at the start, having a high lactate is a really good marker of the severity of their illness, okay? And I think repeating it after a few hours is important to just make sure that you're resuscitating them appropriately. But just because the lactate is high, they don't need to keep getting more and more fluids to try and bring it down. We all have exogenous epinephrine or adrenaline. So if somebody is responding well, or a young person, and they're responding well to your resuscitation, they will be able to mount a high lactate. Whereas an older person who's run out of their endogenous epinephrine, they might not be able to raise a high lactate without vasopressors, and they will look like they're not getting sicker, but they actually probably are the sicker patient. So number 2 is, what's the optimal fluid for sepsis resuscitation? So this is a hotly debated topic since I started working in emergency medicine and before that. And recently we're getting some good studies. So one of the big topics from probably 15 years ago was colloids versus crystalloids. So one example would have been hydroxyethyl starch, and that's been shown to increase renal injury and probably increases mortality as well. The SAFE trial from New England Journal of Medicine in 2004 looked at albumin 4% versus normal saline, and they found no difference in outcome, but the sepsis subgroup showed a mortality benefit when you used albumin. Now, that study was done in intensive care as opposed to the emergency department. We don't normally have albumin available in the emergency departments. And another really interesting point is that all the older studies that were comparing colloids to crystalloids were comparing the colloids with normal saline. And that's probably something that I would not do anymore. So I think there's a big trend in the emergency departments, and probably the intensive care departments, to not load people with high chlorine, because that'll give them a hyperchloremic metabolic acidosis. Next slide. So the big question is, should we be giving them normal saline versus something like Hartmann's or Plasmolite, so something balanced? So there was a trial in 2018 called the SMART trial, where they looked at almost 16,000 ICU patients, and they compared normal saline with balanced solutions, so Ringer's or Plasmolite A, at 30 days or to hospital discharge. And the balanced solutions showed a decreased renal injury, decreased need for renal replacement therapy, and lower persistent renal injury. And the sepsis subgroup analysis, which it was retrospective, but I think the data is there, that looked at 1,641 patients, and that showed an increase in the mortality rate with normal saline from 25% to up to 29%. So for every 20 patients that you treat with normal saline, that you could have treated with Hartmann's or Plasmolite, one of them will die. Next slide, please. So the answer to that question is give either Hartmann's or Plasmolite. Next slide. And the final question, so what's the optimal approach to selection, dose titration, and escalation of vasopressor therapy? So norepinephrine is the first go-to vasopressor in sepsis, and there's lots and lots of studies on that. They used to use dopamine a lot in the States, but that used to increase arrhythmias, and I haven't seen dopamine used in Australia or in Ireland at the moment. I think previously what we did was if someone had a refractory hypotension to norepinephrine, then we would either add in epinephrine or we would add in vasopressin. But there's a bit of a trend now to, rather than adding them in, changing them over to a different one, because some people might respond better to a different vasopressor. In emergency medicine and in ICU, we'll often use peripheral vasopressors. So that's an alpha blocker, either metaraminol or phenylephrine, as a temporizing measure while fluid is being administered and central access has been obtained. Next slide. And there is evidence that delaying vasopressors will increase mortality. So there's a couple of studies there from Crit Care in 2014 that said if you delay them by more than 2 hours, mortality will increase. And then there's a more recent one that said if you delay it by more than 6 hours, your mortality will increase. Now, the ARISE fluids trial from 2019 was an observational study, and they showed no mortality benefit with early versus late vasopressors, and they defined 2 hours as their time. However, it was a retrospective study, so the sicker patients were getting vasopressors earlier. Okay, so in that study, the people who were sicker and got vasopressors earlier had a lactate of 5 versus a lactate of 2.9. So, and they also the patients who were sicker who went on to vasopressors earlier had less fluids administered. Okay, overall. So I think what happened in this study was that the sicker patients were getting earlier vasopressors. And obviously, when you start fluid earlier, start vasopressors earlier, you're trying to limit the amount of fluid that the patient is getting. So the sicker ones, even though there was no mortality benefit, I think that the early vasopressors did make a difference. Next slide. And then interestingly, there was a study by Delaney, Finnis and Belomo in 2020 in Melbourne and Australasia as well. So they also showed no mortality benefit with the use of peripheral vasopressors over central vasopressors in sepsis. So they had looked at 937 patients, which was a post hoc analysis of the ARISE trial. The patients that had the peripheral vasopressors, they did note that they had shorter time to antibiotics and a shorter time to vasopressors. But what was happening as well was that the sicker patients were also getting vasopressors early. So your sicker patients were getting antibiotics earlier and vasopressors earlier. So the sicker patients was most likely a confounder. Next slide. So the take-home points about vasopressors. So fluid resuscitation first. Okay, so you only give them vasopressors if they're unresponsive to fluid due to vasoplegia. Alpha blockers for the really sick ones. I wouldn't advocate giving alpha blockers to everybody. Or peripheral vasopressors to everybody. It's only for the really sick ones as a bridge to them getting central norepinephrine and call for critical care or for ICU help early. Next slide. So in summary, I think the HSE sepsis form is a really useful guide to picking up sepsis in the emergency department. I think using SIRS is probably more useful for the emergency department staff because we get so many undifferentiated patients that we want to make sure that we're not missing any sepsis. Early appropriate antibiotics, source control from our surgical colleagues, personalize the IV fluid rehydration. Don't just give 30 mL per kilo to everybody. Use ultrasound if it's available, and if it's not available, get it in your department and learn how to use it. Use balanced solutions, so Hartmann's or Plasmolite. Don't chase the lactate. The lactate's useful as a guide, but don't be rehydrating them based on a lactate that's not dropping. And early vasopressors, but fluid challenge them first. Thank you.
Thank you very much, Simon, for the second of two very interesting talks. Sorry, yeah. And as an older emergency physician, I find the chat about peripheral vasopressors very interesting, but I think what you're saying is that it's for use in the really big sick.
Yeah, I think so, yeah.
As a bridge to central lines as opposed to forget the central lines or anything like that.
Yeah, no, I think...
Yeah.
No, I think the practice of giving them temporizing vasopressors, but then once they're not sick anymore, then they're good to go home is not really ideal. If they're getting vasopressors, you've made the decision that this person needs vasopressors in intensive care.
Yeah. Okay. Thank you very much. I've no new questions from tonight, but I remind people the chat function is there. I have 6 minutes before everybody loses interest. I have some questions from earlier that I might put to Simon and Martina now. Just Martina, if I could ask one of my own questions. In the slide that you showed about mortality rates in surgery versus medicine, do you know, is there any differentiation made between patients whose reason for surgery was to control a source of sepsis versus patients who underwent a surgical procedure and then developed sepsis?
No, we don't have that data, Jerry. And actually, the first audit data came out really following the sepsis guidelines. So one of the things we're trying to work on is to get even collecting comorbidity from height data is really, really difficult. So I think that one of the things the sepsis group was trying to define was an annual audit that would give you more specific data on the patient subgroup that you're talking about. But what did come out and what's really obvious is that having surgery itself seems to be an added risk for sepsis, to the sense that anybody having surgery, particularly there's certain age groups over 65 in particular, and when you move to patients over 85, the mortality quadruples within a very short space of time. So there seems to be very specific red flags with surgical sepsis. And I just know from our surgical group in Crumlin, there are often very specific surgical site infections like sternotomy wound infections that we've spent a lot of time trying to find out why in particular they are, they cause such morbidity and mortality. And I'm sure for the general surgeons and the colorectal surgeons, I'm sure they have certain patients that seem to have an even higher risk, even if they don't, even if you're not thinking that when you're planning your operation. I don't know if you'd have any question about that, Ronan.
Ronan, I see you have your hand up. You're on mute.
Sorry. There you go. Very unlike me to be muted. I think it's always a question about frailty and the risk of surgery, and certainly we do come across situations, acute situations, particularly with mesenteric infarction, where there's a certain degree of futility about the outcome. But I would say that almost never should you back off trying to get source control for sepsis. But you also have to be aware of damage limitation surgery, and so it's source control and get out, and don't end up with a cold, hypotensive, bleeding, coagulopathic patient. That's what you want to absolutely avoid. The reason to put my hand up was to ask both of you, or all three of you, about the real difficulty of access to high dependency and intensive care. Once you've set off the alarm with the sepsis, identifying the sepsis, the early warning score, sepsis 6, one of the real difficulties for the practicing physician and surgeon is access to critical care. And this has been demonstrated to us during the current pandemic, when we've had to outsource, if you like, critical care into areas such as theatres and recovery bays and things like that. What is the momentum can we drive the momentum towards increasing the number of critical care beds by this sepsis strategy?
So I'll take that one if you want, Simon, unless you want to comment on it. But I work in paediatric critical care. It's a different beast, guys. We haven't had a COVID problem, so I feel like a bit of a fraud sitting here. But what we do have is the value of the audit. And I think the more data that we can collect that shows that lack of access to ICU beds, and I think the 2019 annual report actually has a section on it that I wrote about access to critical care being one of the things that alters morbidity and mortality. And I think that unless we publish both national and local data, I think it's very difficult to convince anyone to increase the number of ICU beds. So I know that the Michael Power and the group, I got an email this week. I think the HSE are putting in a number of added adult beds, and that is and they are coming online fairly smartly, probably as a result of COVID, but also probably as a result of highlighting the deficit in the last 20 years. And it's my understanding that there is a big push on to increase the number of adult ICU beds.
There certainly is a big push, Martina, but I think staffing them is an issue also, isn't it?
Yeah. Well, and again, yeah.
But I would just put it to you that when you're next doing an audit, time from the time to critical care access is a very important variable. I mean, we have something around 6 beds, high dependency beds per 100,000 population, which is about what they have in the UK, and Germany has 35.
Yeah. I don't know, Simon, your access to ICU where you are in Cork, is that an issue?
ICU capacity in CUH is not very good. So I trained in Melbourne, so like the Alfred Hospital probably has about 50 ICU beds. So they're a major trauma centre. They will have loads of beds for the trauma patients that come in that get referred from the rest of the state. All the ICU capacity in all of Victoria is on a website, and all of the ICUs will use retrieval teams to transfer patients around the state depending on need and requirement. So it works really well. And I think having come back and seeing the queues for ICUs, or the ICU teams having to say, do you know something, we haven't got space and we're going to have to palliate this person, whereas people should be getting a fair go. That's probably the big difference between Australia and here.
Actually, one of the things that I'm actually involved in at the moment is NOCA are writing our national summary for paediatric ICU, and I think that it would be great if NOCA took over the writing of the sepsis annual report, and it gets more credence from a national audit group, and it's produced nationally, and I think that the recommendations in it could very specifically look at specific patient groups and mortality, and how we could change that. I think NOCA are very influential. I think it would be really good if they would.
Can I use Chairman's prerogative rather? Both of you interestingly mentioned a very interesting clinical sign, capillary refill time, and it is fascinating. Central capillary refill time I've always found very useful personally in sick children. Are there any caveats associated with the use of that, do you think? Or
But there is a really nice paper, Simon, I don't know if your JAMA paper on cap refill time that the adult group published. For us, it's a no-brainer in PEDS. We use it all the time. Every monitor in our ICU has a central and peripheral temperature difference. There's 2 temperatures on every patient that's admitted. It's there all the time. It's not something the adult group use, but I know that there was an adult paper published in JAMA about 3 or 4 years ago. Simon, I don't know if that's the one you were referring to, that looked at cap refill time and outcome in sepsis. Did you see that?
Yeah, so that was the ANDROMEDA shock trial. So I mean, that was a study from Central America, and kind of South America. So resource limited. So not every place would have access to lactate or VBGs regularly. So I mean, cap refill is an excellent marker. It's used in kids all the time, but I think we should use it in adults more.
Absolutely, I think, and there is a nice paper on that from that JAMA group looking at it.
So I know we're over our time now. I have 2 questions here that are opposite sides of the same coin, I think, but I might just throw out there. I'm not sure whether I'm asking the right panel or not. One question is frailty index routinely checked on all elective surgeries? And the other that I think we've already kind of referred to is, what is the cap for surgical intervention in elderly patients with sepsis?
Oh, I'll have to refer to the surgeons to that, because that's definitely not.
Well, if I might take President's prerogative.
I was hoping you would.
Yeah. Well, with regard to frailty, I think this is of increasing interest in terms of actually quantifying it. I mean, you will be familiar with the eyeball test, which we all instinctively use. But we looked for a big grant proposal, and we just came up short of triaging or randomizing older patients to going to see a geriatric consultant, as well as the anaesthetic pre-op assessment clinic. And thinking that the geriatric pathway would assess the frailty in a more robust manner and address it. But prehabilitation is becoming a real issue. But of course, in the septic patient, prehabilitation is not possible. I mean, it's salvage where possible. And I did mention the word futility earlier. And certainly if you've somebody in whom it is clearly futile, then that's what it is. But I would hasten to add, this is not a decision that should be made by a single clinician. And getting a senior colleague to give you a second opinion is the very least any patient could expect and any family could expect. And I've always practiced that if there was a decision about somebody being unfit to go for a salvage procedure, then I would always ask a colleague. And that advice is always available and always freely given.
Thank you very much.
We have a saying for our surgical patients. I know PEDS is different, but we say to the surgeons, never too sick to operate. I don't know what Simon thinks from the frailty score.
Is, Martina, that children can bounce back, and it's extraordinary, whereas adults don't have the same resilience.
Simon may have more on the frailty score.
I mean, we use the frailty score all the time in the emergency department, especially for referrals to the intensive care unit. So is this person, if they've got a low score, is this somebody who will be able to get off a ventilator, or who will have a period of time that vasopressors will get them over? But the person who's moribund, who's not going to get better after vasopressors, who's going to be on a ventilator or in ICU for a month, is probably...
I think it's a very important factor, and having just worked the weekend, got an increasingly important factor to consider rather than a single factor. And I think the advice to get a second senior opinion, before you take crucial decisions, is quite important. I see a question coming in there that I think is the subject of a future webinar all by itself. So I'll just note it from Paul Valve rather than ask any answer. Given that the early recognition of sepsis is so vital, should all emergency departments a 24/7 consultant cover? That's definitely a webinar all by itself.
On that note, I think we should probably bring the proceedings to a close. Otherwise, we'll be here till 3 in the morning.
Indeed.
Jerry, I'd like to thank you, Martina and Simon, for a really interesting and very important topic. I hope that all of those who listened in enjoyed it, and you might even want to go and do that 1 hour of HSELand revision, and you'll get 2 lucky CPD points for it, which means you've only got 48 more to get. Actually 47, because you'll have got 1 for tonight. I want to thank the backroom staff, Pádraig Kelly, Pauline Lyons, Paula Mansell, Samantha Hansen, Catherine Jordan and Janelle Sherlock, because it does take a lot of resource in the background to bring all of this together, and particularly thank the Vice President Laura Vianney, who has been instrumental in bringing all of this together. Our next webinar will be on the 13th of October, which will bring together contributions, and it's up here, a regional update from Cork and the South-Southwest Hospital Group, chaired by Professor Paul Redmond. We'll be looking at advances in minimally invasive endocrine surgery, emergency surgery in a general hospital with Mr. Kayal from Bantry, and cancer genetics in 2021, Derek Power from Cork University Hospital. So you've got the list of other topics up there. We have decided to make it every second week because we believe we can give better value and more interesting topics in doing that. So I want to thank all and hope you've enjoyed it, and I look forward to seeing you on Wednesday, October 13th. So good evening to all.
Thank you.